It's a real potpourri of different things, so we'll just take it until we run out of time here. So this is a 24-year-old female medical student who came to us with a complaint of right lower quadrant pain. They were actually predominantly thinking more in terms of either an ovarian cyst or potentially of even appendicitis, although she didn't really have any kind of febrile situation going on. What we noticed when we did the endovaginal scan on this woman was that there appeared to be a mass-like area within the endometrium. But I'm not sure that we picked this up prospectively, but if you look at this area here, it also appears that there's sort of an indistinct line here where it almost not invades, but actually seems to be indistinct and goes out into the myometrium. Our astute technologist actually put color Doppler or power Doppler on in this particular case and found a lot of flow that seemed to extend out of that endometrial area into the myometrium. Now this was a young female who claims to be not sexually active. They actually had done a beta HCG on her and it was negative. We then, if we put the color on, you can see there's this just striking area of flow. And when we look in some other areas with the clip, you can actually see there were these large, what were essentially draining veins going toward the surface and in and out of this area. And when we put the spectral Doppler onto this area, you can see there was this kind of bidirectional, very, very low resistance flow. And in these draining veins, you can actually see that there is arterialization. So what we're actually dealing with in this particular case is a classic example of a AVF of the uterus. Now these are obviously they're not common, but that's not that rare. And the important thing to keep in mind from the patient standpoint is the history. And that is whether these are congenital versus acquired. And so if they are congenital versus acquired, if they're acquired, of course, the patient will have told you they will have had some sort of instrumentation in the recent past. And the thing to keep in mind about that is from a treatment standpoint, if they are acquired, many of these will actually resolve. So aggressive angiographic treatment of an acquired AVF in the uterus is probably not indicated. So these can probably be followed over time. Obviously, these patients can get into trouble if there is a pregnancy going on while they have this. So the difference between the congenital ones will often need to be embolized, whereas the acquired ones will often go away on their own. One other thing to keep in mind, and I mentioned that this patient had a negative beta HCG. If you look at this image or this set of images, which is from a different patient, you can see it's a very similar situation. You have this kind of poorly defined area of the upper endometrium here. When you put the color Doppler on, you can see that there's this very intense area of enhancement or of flow. And this was a different situation. This was a patient who was 1 week after a spontaneous abortion. And just to keep in mind that these patients may have retained products. And retained products can actually have a very similar appearance, at least with color Doppler. So do keep the two in mind, that the history is very, very important. History number one, if it is an AVF, is it congenital versus acquired? Then number two, in the back of your mind, when you see this intense area of color Doppler or vascularity extending out of the endometrium, if the patient has a proper history, that this could have a very similar appearance on ultrasound to retained products of conception. And again, even that can have this very, very low resistance vascular flow, and the two can be almost identical sonographically, but a very different situation. So completely switching gears, this was a 68-year-old woman who was actually in the hospital being evaluated for a pre-liver transplant situation, but in this particular case she came in with right upper quadrant pain. If you look at these images, you can see that she has a large amount of sludge within the gallbladder, which of course is a very non-specific finding. Obviously sludge can occur just from not eating in these patients, but the wall does appear to be thickened. And again, thickening of the wall is not an uncommon finding in patients with chronic liver disease. So that really didn't tip us off to saying a whole lot either. But what we did see when we looked very closely at this patient, she has a little bit of pericholecystic fluid, again in a cirrhotic. That's not a very good sign for acute cholecystitis. But look at the wall. If you follow the wall very closely, you can see here in the anterior part of the wall that there is a collection of punctate echogenic foci, and if you look on this image, you can actually see that the wall seems somewhat discontinuous and that there is some fluid and debris collection outside of the gallbladder. So we suspected that this woman may actually have emphysematous cholecystitis, which of course then leads to or is a setup for developing a perforation. And in fact, that's what we suspected that this woman had. She was not in exactly great shape to go to surgery, since she, as I said, was on the transplant list, very close to being transplanted. So what we wound up doing with her was taking her to CT. On CT, you can see that there's confirmation of this air within the wall, and so we put a cholecystostomy in her under CT guidance, drained a lot of pretty gunky looking material out of her gallbladder, calmed that situation down, and she was eventually transplanted several weeks later. So always be very careful when you're looking at the gallbladder wall, and again, when patients have either gangrenous cholecystitis or emphysematous cholecystitis, the pain may miraculously go away. The Murphy sign will typically be negative because these things then get denervated so they don't hurt anymore. So that can be a very controversial or thing that can really fool you. But again, always look to see the wall. Make sure you don't have little echogenic foci within it. These are not shadowing real well, which you'd expect from the air. But then there's this little pocket over here extending out representing the perforation. Now, since we're on the subject of gallbladder disease, this was a 64-year-old man who was also referred to us from another hospital. Actually, he was referred to us for cardiac issues and was going to undergo a bypass surgery, but he presented originally to the other hospital with cardiac issues and right upper quadrant pain, and sort of an illustration of the same situation. When we saw him, said, "Oh, well, no, I'm getting much better. My pain's going away. The right upper quadrant pain doesn't hurt that much anymore." When we looked at his gallbladder, obviously you can see this big stone sitting back here with shadowing, but the remarkable thing in his case was this series of membranes. And this is a classic finding of gangrenous cholecystitis. And so when you have gangrenous cholecystitis, what we're told is that the membranes in the gallbladder, the mucosa, actually sloughs. And so if you ever see a patient who has these membranes within the gallbladder, this is a classic feature of gangrenous cholecystitis. You may or may not see air, as we did within the first case, and the other red herring about this is that, again, these patients may denervate the gallbladder, and he'll come to you and say, "Well, gee, my pain's getting better. Why are you so freaked out by the images that you're looking at?" So do keep in mind that both of those, emphysematous cholecystitis, gangrenous cholecystitis, can actually present with resolving right upper quadrant pain. This is another scary case. This is a 61-year-old man who was seen with a history of melanoma. Looking back through his records, we actually found his initial scan, which was performed in 2007, and this was called sludge. Okay, so a little sludge never hurt anybody. He went home, no problem. I think what's particularly interesting is that he has a history of melanoma. He had a repeat scan in 2011, and luckily this was from outside. This was called sludge again. Obviously, to me, sludge should layer. Sometimes it's very slow to move from one part of the gallbladder to the other, but particularly in a patient with a history of melanoma, which is known to sometimes go to the gallbladder, when you start to see a lot more material within the gallbladder, you really need to start thinking of something bad. Now, theoretically, melanoma may go to the wall, so the other question in somebody like this is this nodular mass that's growing within the gallbladder now over 4 years. actually could it potentially represent a primary gallbladder carcinoma. In this particular case, we actually put color on it, and you can actually see that there is some flow, telling us this is clearly not sludge, and that can be helpful for making that differentiation. But needless to say, we finally talked people into taking this man to the operating room, and I guess luckily for him this turned out to be a gallbladder carcinoma rather than metastatic melanoma. But remember, metastatic melanoma is one of those nasty players that can show up in all sorts of weird places like the gallbladder or the spleen, but it is kind of a scary situation when you look back at this, that obviously when we did the scan originally, we didn't sit around and wait to see if this stuff actually moved. And one of the few cases where I've actually seen a gallbladder cancer develop, I think the only good thing about it is that in theory, it's probably not a real aggressive disease, that it does grow slowly over time, and in 4 years, it had gotten to this point. So luckily, after 4 years, we finally talked people into intervening on this man and taking out his gallbladder with his gallbladder carcinoma. So testicle time. We see a lot of these, particularly at our county hospital, some real bad ones actually at the county hospital. And one of the main things I guess we think in terms of is, do they stay or do they come off? And one of the things we do with ultrasound is frequently make that decision. I think everybody would probably be aware of what entity we're dealing with here. A pretty dramatic looking image. When you see this, there's this large triangular area with multiple tubular structures within it. Obviously, as I said, I think as most people know, this is a leave alone guy. This is a dilated ready testes, and obviously something that's completely benign. Frequently there's this triad of findings in patients with this. You'll see the dilated ready testes. Often these patients will also present with intratesticular cysts, and you may also have epididymal head or epididymal cysts as well. So the three of them frequently occur together. But again, obviously, as I said, this is a very dramatic appearance, but in fact is completely benign and not something you want to do anything with. This is probably the most common palpable mass that we see in testicular imaging. This is a simple cyst within the epididymal head. These can be multiple and actually in some cases can get pretty large. The only other thing about them that's worth noting is sometimes they will have debris in them. But again, this is nothing that I think anyone should be concerned about, the fact that they may develop a little bit of debris. But certainly the most common cause for a palpable mass in a male patient. Now that can be actually contrasted with this patient, where you see the testicle here. You can see a solid mass that is intervened between the testicle and is probably arising from within the epididymal head. Now I think most people would agree that the one thing we do with ultrasound that's very, very important in the testicle or in the scrotal examination is determine whether you're dealing with an intra versus extra testicular mass. Obviously, if it's an intratesticular mass, it's going to come off, and along with it, so is the testicle. If it's an extratesticular mass, most of these are going to be benign, and depending upon the comfort level of the urologist and the patient, many of these can be either followed or have no intervention at all. This one was removed and did turn out to be an adenomatoid tumor. This is a benign tumor of the epididymis, and as I said, the vast majority of epididymal masses in an otherwise asymptomatic patient will be benign. So for the most part, people will either follow these or do nothing more depending upon the appearance. This one, as I said, because of the patient basically and the surgeon decided that it was better to remove it. This, of course, is the opposite end of the spectrum. This is a 26-year-old white male. White males have a higher incidence of testicular germ cell cancers. And of course, as we all know, this tends to be a disease of young males. So usually between the ages of 25 and 40 is the most common time for people to develop germ cell tumors. There are various cell types of germ cell tumors which can affect, primary tumors that can affect the testicle. The most common of which, of course, is seminoma. There's nothing that's absolutely pathognomonic about one cell type versus another. another. Typically, seminomas will tend to be better defined and more homogeneous internally, like this one. When you start to see calcifications or disorganized areas within the mass, cystic areas within the mass, start to think of non-seminomatous germ cell tumors. But again, there's nothing really specific on the ultrasound that would enable you to make a histologic diagnosis. Now this is a different patient. Obviously this is a 39-year-old Hispanic male, and he presented with a large testicular or scrotal mass. In this particular case, the imaging characteristics or the ultrasound characteristics are quite different. Instead of that single, well-defined, relatively isoechoic mass, you can see that this looks like a bag of potatoes. You can see that there are multiple confluent masses here. This mass is obviously quite large compared to the opposite testicle. And I think the differential is not specific here. One of the first things you'd probably think in terms of is lymphoma. Certainly primary testicular lymphoma is a possibility in a multilobulated mass like this. He's relatively young, and so the other thought here would be that you can get multifocal germ cell tumors. So just the fact that you've got multiple masses within a testicle doesn't get you off the hook from the standpoint of a germ cell tumor. This did actually turn out to be lymphoma, but again, multifocal germ cell tumors are possible either unilaterally and even more rarely, but occasionally bilaterally. I've seen that as well. Now this is a 77-year-old man. If you look at the size markers here, you can see that this poor guy had a scrotum somewhat similar maybe to a cantaloupe. They were these two hugely enlarged testicles, painless for the most part, no real well-defined mass. And so this is really the other manifestation of testicular lymphoma. So you can have two different appearances. Sometimes, probably more commonly, you'll have the multifocal lymphoma like we saw in the previous man. In this particular case, this is more diffusely infiltrating, but particularly in an older man with markedly enlarged testicles or multiple focal masses bilaterally. As soon as you see bilateral anything in the testicle, one of the first things that should pop into your mind is lymphoma. So keep that in mind. And again, the two different features or two different types, one which is multifocal masses versus this which is more infiltrating. Obviously, in both cases, you want to go up and look at the retroperitoneum, see if there's any kind of nodes in the retroperitoneum, although the same could obviously be true of seminomatous or germ cell tumors. They obviously also metastasize to the retroperitoneum. Typically, you'll see that in the area of the renal veins. So typically, the metastases will skip the pelvis and then go up the lymphatic chain and deposit themselves in the area of the renal hilus and of the main renal vessels in the retroperitoneum. Now this is another older man, he's 76 years old, who presents with a right scrotal mass, obviously accompanied by a huge varicocele. We do everything big at the county hospital. Nothing presents very early there. And in this particular case, he had a history of prostate cancer. So do remember again, particularly in the older patients, to make sure to see, is there a history of primary malignancy? It's not common, but they certainly can go to the testicle. And in this particular case, as I said, he had a history of prostate cancer, and this in fact did turn out to be metastatic prostate cancer. And actually that is the most common primary to go to the testicle or to the epididymis is actually prostate cancer. This was another man who presented with a scrotal mass. In this particular case, you see this very odd looking mixed echogenicity mass in the area of the testicular of the epididymal tail. Again, this was a patient who was 55 years old, had a history of retroperitoneal sarcoma, and this was metastatic to the epididymis. So you can have metastatic disease both primary to the, or not primary, but metastatic disease to the testicle itself, and actually more commonly to the epididymis. So in both cases, make sure that you look at the history in these patients as to whether they have any kind of primary malignancy elsewhere that may have spread. Obviously, the other thing to think in terms of, and we talked about this before, was lymphoma, or particularly in children, leukemia. They can also have leukemic rests within the testicle, and sometimes are actually will maintain these rests within the testicle even though treatment elsewhere may be relatively successful. This is probably a more common scenario at our hospital. This was a 26-year-old man who presented to the emergency room 2 weeks ago and was treated for epididymoorchitis. He presented 2 weeks later back to the emergency room with increasing pain and swelling, and you can see in this particular case he's got marked enlargement of the epididymis. You can see that there are multiple cystic spaces within it, and that it is hypervascular. And so this is a classic picture of a patient who, when I actually talked to him, his English, shall we say, wasn't very good, and it turns out he didn't really understand the fact that he was supposed to take those pills that they gave him. So unfortunately, he really never adequately treated his epididymoorchitis and came back now with a developing abscess. So this is a classic finding, again, multiple cystic spaces. Do remember that when you scan for epididymoorchitis, that about 30% of epididymitis will actually be focal, and the most common place for focal epididymitis or epididymitis is in the tail. And remember, the tail is relatively mobile, so make sure that you or your techs, when they scan for these kinds of situations, always look below the testicle to see if they can find this enlarged hypervascular epididymal tail. It's a very common place for focal epididymitis to occur. Some patients who forget to take their pills actually get into more trouble. This was another man, 32 years old, again, same situation, 2 weeks of questionable treatment for epididymoorchitis. In his particular case, you could see that there was tremendous vascularity around the testicle. You can see that there is what likely represents a pyocele, but what was particularly appalling about this was when you pushed on the testicle, it moved. And what will actually happen in some of these cases, they will actually develop a venous infarction, and so that testicle has basically infarcted itself and is liquefied. And so you could actually see motion within it, and this can sometimes happen in patients who have inadequately treated epididymoorchitis. It's really the same thing essentially as a torsion, except in this particular case it's probably a venous infarction. The testicle swells so much that the blood basically can't exit from it, because remember, the tunica albuginea is pretty tough, and so the flow actually just simply can't get out, and they just infarct the entire testicle. Obviously, in this particular case, they will have to remove the whole thing. And just lastly, this is a 66-year-old black male. He had some vague symptoms attributable to the testicle pain-wise, and you can see these several small masses. And do keep in mind that one of the things that can also affect the testicle are granulomatous diseases. They can affect both the testicle and the epididymis. He had no real history of TB or anything like that, but on closer questioning, he actually had a history of sarcoid. And so one of the things that can cause small masses within the testicle is sarcoid. And again, in this particular case, you don't want to go in and perform an orchiectomy on this man. This was followed over time, and these things stay relatively stable. But do keep in mind, if the patient has a history of sarcoid, they can have these small, probably little granulomatous nodules that develop within the testicle itself. But these are benign and should not be either biopsied or undergo orchiectomy. So you can't have too many, is the old saying. This was a patient who presented with this unusual mass, and what you can see here is probably a supernumerary testicle. It's actually attached to the primary or the main part of the testicle. We have another case recently, which the tech actually, we have a very interesting tech who does work all night long in the county hospital, and when I walk in the morning, he always has something really bizarre to ask me about. And one morning came in and said, "Is it possible to have 5 testicles?" And I thought, wow, that's really cool. But in fact, it is. And so we have actually heard of cases where you have not only 3, which is the more common, 4, and in our case, we had one with 5. So balls, I suppose, is the word there. But the problem was these things torsed. And so they would torse and detorse on this poor guy, and he would present with testicular pain. So unfortunately, as many cases happen in our county hospital, he got lost to follow-up. But do remember that as a scrotal mass, sometimes you can actually see that there is a supernumerary testicle. 3 is the more common. In this particular case, it's actually attached. But I don't think anyone would have too much trouble saying, you know, the blood supply to this was similar, the area, you know, the echogenicity was similar, this is probably not a tumor. So just do keep in mind that sometimes there may be some extra things hanging around in there, and that they don't really want to go to surgery. So, completely changing things here. This is a patient who presented with a TIA. And when you look at his numbers, here's the common carotid artery, there is the internal carotid artery, and you can see in the internal carotid artery that the peak systolic velocity is about 200 centimeters per second. His velocity ratio is about 3. So I think if you think back to my little chart from the carotid the other day, these are pretty classic numbers for about a 50 to 69% stenosis. On the other hand, when you look at this guy, visually, you see that there is a very, very apparently narrowed lumen, and that the original lumen was fairly large compared to this. And I talked a little bit about this yesterday as to which do you believe. Do you believe your visual appearance of a very, very tight, nearly occlusive lesion versus the numbers that you see here based on the Doppler, where you would probably diagnose a 50 to 69% stenosis. And so, as I mentioned yesterday, when you look at something like this, sometimes you really have to go with your eyes rather than with the numbers. And in this particular case, it's another one of these very tight, nearly occlusive lesions. You can actually see, again, that the distal ICA beyond the stenosis is small compared to the external, and this was a nearly occlusive lesion. It was focal, and of course this then would be a candidate for endarterectomy. But do keep in mind, I mentioned yesterday that for the most part, we tend to rely more upon the Doppler than we do on the visual assessment, but this is one situation where the opposite is true. If you see what looks like a very narrowed lumen, remember that in fact those numbers may be off, and that you may underestimate the degree of stenosis if you only base it upon the velocity measurements from the Doppler. So this is an interesting woman. She was a 42-year-old lady, and she presented with what she described as a pretty long-term mass sitting underneath of the midline, underneath of her mandible, in the submandibular area. And when we looked at her, with ultrasound, we found that there was this heterogeneous mass, had some little echogenic foci, so we were kind of wondering, could this be an ectopic rest of thyroid tissue? And I think the CT actually shows it better than the ultrasound, although we saw the same thing on the ultrasound. When we went back and looked at her thyroid region, or where the thyroid should be, there was nothing there but fat. And the CT scan, I think, is kind of interesting when you look at it. You can see the same mass sitting up here underneath of the mandible. It's enhancing quite a lot. And this is a well-known entity in the pediatric literature, although obviously it may apply to adults as well, as was the case here. But this was actually agenesis of the thyroid, and this turned out to be ectopic thyroid, which frequently will happen. Remember that embryologically, the thyroid descends down from above, and there may be remnants. In some cases, you may have a thyroglossal duct cyst. In other cases, where it never made it down to the area where the thyroid normally lives, in this particular case, there was a large rest of enlarged thyroid tissue, which actually turned out to be a colloid nodule. So patients who present with these midline masses, most commonly and easily diagnosed would be a thyroglossal duct cyst, but do remember that sometimes you will find that there's actually thyroid rests along that midline area as the thyroid ascends. This is another woman who presented with a midline mass, submandibular mass. And I don't think anybody would have a problem making this diagnosis. Quite different from the last patient. You can see this large cystic structure here, and this obviously represents a thyroglossal duct cyst. Frequently, these things will insinuate themselves between the two sides of the hyoid bone, so you'll have almost this figure 8, and this is a very classic feature of these midline thyroglossal duct cysts. And you can see very similarly on the CT scan, the more anterior palpable part of it, but that it actually does extend back in here behind the hyoid bone. And again, that's a very typical feature of a thyroglossal duct cyst, very different than the ectopic thyroid tissue we saw in that other patient. One thing to keep in mind, I think a lot of times we depend so much on CT when it comes to retroperitoneal masses. We forget about ultrasound, but certainly when we're looking at the retroperitoneum, we can, particularly in thinner patients, get very good images of what's going on. I think Ulrike showed a case yesterday, I think, or Leslie, of the floating aorta, but in this particular case, this is the sonographic version of it. You can see that the aorta has been lifted off of the spine and that there are multiple large nodes sitting around the retroperitoneal vessels here. Obviously, depending upon the patient's age and sex, your differential diagnosis would be varied. This was a young man, and you can see here on the CT scan that there are large lymph nodes surrounding the aorta. And so in this particular case, the things we obviously would think of would be, again, lymphoma, or in a 35-year-old male, obviously you'd be thinking of a testicular malignancy metastatic to the retroperitoneum. But what was interesting was his testicular examination was actually normal. There was no obvious mass, but in fact, one of these things that can happen is you may have what's called these burned out tumors of the testicle, which actually present as widespread metastatic disease, but the testicle itself, by palpation, was perfectly fine. Obviously, you can see this very jagged hypoechoic area with calcifications. He actually has a second mass within the testicle. So again, for these patients who have retroperitoneal adenopathy, even if the testicular physical examination is normal, if it's a young male, you probably want to go on and look at the ultrasound. There's actually a name for this called an Azzopardi tumor. That's something which we will all forget as of tomorrow, but it's a burned out testicular tumor, and for all the world, the scrotal examination feels perfectly normal, but then they present with widespread metastatic disease. Just one or two more cases, or one or so more cases that are related here. This was a 65-year-old woman who presented with intermittent flank and back pain bilaterally, and when we looked at her CT, again, you see this retroperitoneal mass. The difference, I think, and I don't know that this can be applied in every case, is this looks kind of different than the nodes. This is a lot more symmetrical and round. It doesn't have that lumpy, bumpy appearance like you get with metastatic disease or lymphoma, and so we weren't quite sure what we were dealing with here, so we decided, we flipped her over and we did a biopsy under CT. Obviously, these kinds of biopsies are not done with ultrasound, at least not in my experience. And so this is another entity that can actually cause retroperitoneal masses, and this is retroperitoneal fibrosis. Obviously, she was probably obstructing intermittently her kidneys, but as I said, don't know that you can apply this to every case, but certainly when I see that lumpy, bumpy appearance, I tend to think more of metastatic disease or lymphoma versus the more smooth appearance that you get with retroperitoneal fibrosis. Again, and they don't tend to be as grossly enlarged as the nodes that you get with lymphoma or with metastatic disease. And again, biopsy is pretty easy coming in from the back like that to make the differentiation if there's any question about that. So I think on that note, we'll call it quits. Thank you.